Hello, friends. Welcome to the Block of the Month series. At this outset, let me congratulate our academic director, Dr. Hetal Vadera. He's the one who has conceptualized the series and implemented on Facebook and YouTube channel of AORA. He's getting a lot of popularities. Thank you, Dr. Hetal Vadera, for giving me the opportunity to present the third block of the month. I'm Dr. Javed Khan from Vishesh Jupiter Hospital Indore, and I will be presenting supraclavicular brachial plexus block PNS guided to you. For next 15-20 minutes, these are our learning objectives. Supraclavicular brachial plexus block, popularly known as spinal anesthesia of the arm, is rightly said, and it is also the bread and butter for most of the anesthesiologists because the major chunk of regional anesthesia practice of all practitioners come from this block. So it is rightly said the bread and butter. Looking into the history, Kolenkov, a German surgeon, in 1911 performed the first percutaneous supraclavicular brachial plexus block on himself, and in 1928 he published the technique. What is this technique? A needle insertion above the midpoint of clavicle in the direction of spinous process of T2 and T3. And this is associated with a lot of complications and mainly pneumothorax. So this block doesn't get popularized much after that. Alan Winnie and Vincent Collin in 1964, they introduced the subclavian perivascular block. Murphy in 1944 described single injection techniques performed lateral to the anterior scalene muscle, directing the needle caudate. Brown and collaborators in 1993, they introduced the plumb bob techniques. The needle is introduced above the clavicle, just lateral to the sternocleidomastoid muscle and advanced perpendicularly to the plexus in the anterior posterior direction. What is brachial plexus? Brachial plexus is a group of nerves that gives motor and sensory innervation of the upper limb. What are its components? 5 components: roots, trunks, divisions, cords, and branches. How it is formed? It is formed by anterior primary rami of cervical 5th, 6th, 7th, 8th, and thoracic first. When it is joined with the C4, it is prefixed by T2, it is postfixed. There should not be any confusion between ventral root and ventral rami. The nervous tissue coming out of the spinal cord are the dorsal and ventral root. These unite to form a spinal nerve. This spinal nerve gives rise to a small dorsal ramus and a large ventral ramus. It is the ventral ramus which form the brachial plexus. The trunks, after coming out from the roots coming out from the intervertebral foramina, they form the trunk. How? Cervical 5th, 6th join to form the upper trunk. C7 continues at the middle trunk. C8 and T1 join to form the lower trunk. These trunks, they travel inferior laterally in the posterior triangle of neck in between two scalene muscles. Eventually, they divide into shorter anterior and posterior division just above the clavicle or the first rib. This division ultimately unite to form cords. How? Anterior division of upper trunk, middle trunk join to form the lateral cord, while the posterior division of upper trunk, middle trunk, and posterior trunk join to form posterior cord, while the anterior division of the lateral trunk continues at middle cord. These cords lies in relation with the subclavian artery and they are named in relation with the subclavian artery. These cords give rise to 5 terminal branches. Posterior cord give rise to axillary and radial nerves. Lateral cord give rise to musculocutaneous nerve. Medial cord give rise to ulnar nerves. And the median nerve is formed by both lateral and medial cord. So we look at the posterior triangle of neck where the brachial plexus lies. Let's have it. It is guarded medially by the sternocleidomastoid muscle and posteriorly by the trapezius muscle. Base is formed by the clavicle. Let us have a look of this close look of the posterior triangle. See, medial 1/3 of the clavicle, we have insertion of sternocleidomastoid. Lateral 1/3 has insertion of trapezius muscle. So the middle third portion is called as a safe zone, or rather a playing zone for anesthesiologists, because we have to maneuver the needle in this middle zone only. If you remove these two muscles, You will find a triangular groove which is guarded medially by the scalenus anticus and laterally by the scalenus medius muscle, intercepted by inferior belly of femoid with the base of the clavicle. This is called interscalene groove. Brachial plexus traverses in between this groove. If you look at this picture, if a point is marked at the tip of the interscalene groove, midpoint of clavicle, and pulsation of axillary artery, if you join this line is called line of Grossi. Importance of the line is that although brachial plexus is enclosed in a brachial sheath, so if you breach the sheath with a needle and instill some local anesthetic, it will block the brachial plexus distal to that. Various approaches at the interscalene level, roots are blocked, supraclavicular trunks are blocked, at the intraclavicular division, the scots are blocked, and at the axillary level, terminal branches are blocked. Any of the analgesia of anesthesia of the upper limb distal to the shoulder or mid-humeral area is covered with this block. So you can do any surgery below the shoulder with this block. Patient refusal, local infection at the site, patient on anticoagulation, and allergic to local anesthetic, the absolute contraindication as usual as the any other block. While a neurological deficiency of the involved arm, a patient with the chronic obstructive pulmonary disease with contralateral paralysis of pharynx nerve or recurrent larynx nerve, they relatively contraindicates the use of this block. A proper pre-anesthetic checkup and optimization of the patient for the comorbid condition is must. After optimization, when patient is taken, strict non-invasive and invasive monitoring with patent IV line and workstation, and every kit of the regional anesthesia should be ready. Of course, including interlipid 20% to counteract last. A number of peripheral stimulators, advanced models now available, which have different modalities. The usual settings, the intensity of current is 0.8 to 1 milliamperes, pulse width 0.1 milliseconds, frequency current 2 hertz. Try to keep the current intensity less than 1. Otherwise, patient who is already on a fracture or some disease will have a lot of pain because of the plethora of combination mixture of the motor responses. 22 gauge short bevel insulated needle, maybe from 3.5 to 5 centimeter can be taken. More than 5 centimeter doesn't need it. If your plan E to give a regional anesthesia, then in condition with the regional anesthesia fails or there's a complication, you should have a plan B of general anesthesia. That should also be kept ready. Usually it is done in supine position with the neck extended by putting a pillow under the shoulder and contralateral rotation of the neck 40 to 45 degrees so as the chin is in line with the mid-clavicular point. It can also be done in semi-upright position. Important landmarks: lateral border of the clavicular head of sternocleidomastoid. Over the clavicle, a point is marked just lateral 2 to 2.5 centimeter. Lateral to that, a point is taken. This point corresponds with the lateral border of interscalene groove and the pulsation of subclavian artery. This is the point of insertion of the needle. A direction of needle in a classical interscalene, the supraclavicular brachial plexus is downward, backward, and slightly medially. So if you can understand it with the sonor anatomy, there's a picture of at the level of supraclavicular fossa. You see the subclavian artery resting on the first rib, and anterolateral to it is the brachial plexus. The point of entry of needle from the lateral to medial direction, either it hits the upper trunk or slightly medially can go to the corner pocket of brachial plexus. Motor response of stimulation will be a shoulder abduction by the contraction of deltoid mediated by axillary nerve and elbow flexion by contractions of bicep muscle mediated by musculocutaneous nerve. Stimulation of the middle trunk gives rise to shoulder extension by contraction of triceps mediated by radial nerve, and stimulation of lower trunk causes wrist flexion mediated by medial ulnar nerve and finger abduction by ulnar nerve. Patient is properly optimized, plastic checkup is done, and taken into the theater, position is done, landmarks have been laid down, and procedure started. A small amount of local anesthetic instilled, large volume will block the plexus. 5 centimeter stimulus needle is taken and inserted in the direction downward, backward, slightly medially. At a very small distance, you will get the flexion and slight maneuvering the needle. You will also get the flexion and extension both. Very well accepted. You have to reduce the current to get the optimum contraction. Instill the local anesthetic. Your block will be complete. See, 3 centimeter, almost 3 centimeter has gone. Uh, this the surgery is the auricular fixation. This is the right-sided supraclavicular brachial plexus block. Patient is lean and thin, so a 3.5 centimeter needle is used. After local anesthetic, installation of skin subcutaneous tissue, needle is introduced so as to get the proper response. You can see the contraction of deltoid as well as the biceps. Maneuvering the needle medially or slightly getting into a deeper level, you will get the extension response also. Current is reduced so as to get a proper location of the plexus. You can see the needle is directly resting on the corner pocket, the lower trunk, or extension response is there. Local anesthetic is instilled. See, you have a combination of motor response. See, after installation, you can see the fullness at the side. That means whole of the drug has gone into the sheath. Result is obvious. Hardly 2 centimeter has gone. One variant of this supraclavicular brachial plexus block is the subclavian perivascular block. The direction of needle, point of entry almost remains the same. The direction of needle is slightly different. It is posterior lateral to subclavian artery. The idea is that with the non-operating thumb, you will feel the pulsation. You will try to obscure the pulsation, pressing hard on the first rib, and needle is introduced posterior in the posterior lateral direction. See, in the sonar anatomy, you can see the direction of needle very well. Posterior lateral subclavian artery. This is the procedure. The pulsation is almost blocked. And see the needle in the posterior lateral direction, almost parallel to the ground. It has gone into the proper position. You can get flexion extension. Current is reduced to the optimum level. Motor response well accepted. Local anesthetic should have been instilled to get the block complete. The amount of local anesthetic prepared is 30 ml, out of which 15 ml is 2% lignocaine with adrenaline and 15 ml is bupivacaine 0.5% or ropivacaine 0.5%. Total volume given 25-30 ml. In PNS guided blocks, we have to give a volume of large volume of local anesthetic. Adjuvants, they increase the duration of analgesia by 6 to 8 hours. Dexamethasone, 8 milligram, dexmedetomidine 1 mic per kg, clonidine 1 mics per kg. Of these three, dexamethasone by far is the most benign drug. No bradycardia, no sedation to the patient. Pretty safe. How to check for the successful block? 4 P's. If the patient is unable to push arm, then radial is gone. Unable to pull, then musculocutaneous nerve is blocked. If the patient doesn't get pain on the pinch on the index finger and little finger, that means median ulnar nerve has gone. If you're getting a blood aspiration in the needle, that means you're too medial, you have punctured the subclavian artery. Solution is that you withdraw and redirect laterally so as to get the brachial plexus in the proper position. If you have contact with bone, that means you have gone too deep, you're hitting the first rib, then withdraw the needle, relocate the landmarks, and reintroduce the needle. If you have a diaphragmatic twitch, that means you have gone too much cephalic and medial. You are stimulating the phrenic nerve. So remove the needle, goes caudal and lateral, you will get the proper stimulus. The first complication which comes in to our mind is the pneumothorax. But why should pneumothorax develop in this block? Look at this X-ray of the chest. This is the area on the inner margin of the first rib which contains the dome of pleura. And, and this is the area of working of the anesthesiologist. So if your direction and length of needle is up to that level, this level, just outside the inner margin of the first rib, then your needle is okay. But if you're too medial and too deep, definitely you are going to puncture the dome of the pleura. Complication has to happen. In the subclavian perivascular also, the direction of needle is usually this posterior lateral. But if it is infero-medial, then pneumothorax has to happen. One or two pricks are not a problem, but if you are going multiple pricks, then definitely patient will need some chest tube drainage. Patient will have some pneumothorax. Patient, if you are hitting the pleura, patient definitely will have violent coughing. So beware of that while doing this block. You can also check with the fluoroscopy because most of the time we are working with orthopedics people. We have fluoroscopic facility. So in the fluoroscopy, if your needle is well behind this crossroad of the first rib and clavicle, then you are okay with the direction and position of the needle. Injury to phrenic nerve, vertebral artery, cervical epidurals or spinal, dorsoscapular nerve injury, Horner syndrome, stellate ganglions are very rare because working area is far lateral and caudal to these structures. Length of needle should not be more than 3 centimeter. If you are going more than 3 centimeters, you are liable to get pneumothorax and any other complication. A needle should not be inserted too medially. Evoked motor response will be a mixed one because we are working in a small closed area. Always aspirate before injecting the drug, and drug should be injected in small incremental injections. Avoid injecting a higher patient. Patient will definitely have pain and tingling or paresthesia along the area of distribution. Needle should never cross the parasagittal plane medial to interscalene muscle so as to avoid pneumothorax. Whole concentration is to avoid the pneumothorax. Then some rescue blocks. What happens many times you are not able to give up to the lower trunk. So the medial side, the arm and forearm will be spared. In that case, what you have to do to open the axilla, feel the position of brachial of the axillary artery, hold it firmly, and put the needle below the artery, get the stimulation of ulnar nerve, deposit 5 ml of local anesthetic, your block will be complete. Similarly, if you are doing something on the medial side of the arm, then the C8 and T1 or T2 will be spared. That the medial brachial cutaneous of arm, medial brachial cutaneous of forearm, and intercostal nerve is spared. So this area will be unaffected. In that case, you have to deposit 5 to ml of the superficial to local anesthetic superficial to conjoint tendon and fascia of the latissimus dorsi that will block the medial side of the arm. And sometimes the posterior, if you are especially working for the olecranon surgery, the posterior brachial cutaneous nerve is spared. Nothing you have to do a subcutaneous infiltration along the circumference on the posterior side of a weak local anesthetic solution because it's purely sensory now. That will finish your block. Patient will not get much of the pain. There are some references. This technique of PNS guided supraclavicular brachial plexus block is very useful because if you consider this brachial plexus is an hourglass appearance, you will find the supraclavicular portion is the nervous part. Whole of the nervous tissue is condensed in smaller area. So any of the local anesthetic injected at this level will have a rapid onset, will have a dense block and predictable anesthesia with high success rate and low rate of complication. So start using this technique. Thank you so much for listening to me.